Welcome to this episode of the ASHA podcast. I'm Fred Wyant with the American Sexual Health Association, ASHA. We talk a lot about health equity, which often is a conversation around inequalities that exist with health outcomes among a number of vulnerable communities. Today, we're going to focus on rates of syphilis among Native Americans in the U.S., a really overlooked topic when you think about the scope of the issue. Native Americans are hit especially hard with just over 58 cases of primary and secondary syphilis when it's most infectious per 100,000 people. By comparison, the overall US rate was right at 16 cases per 100,000. So there's a pretty wide gap there. A lot of reasons why these communities that are underserved have higher rates of syphilis and other STI, sexually transmitted infections. But it's important to note from the start, it's not because they're doing anything wrong or differently. They're not. But we're going to explore all that today with our guest, Megan Curry O'Connell, a citizen of the Cherokee Nation and a physician and the chief public health officer with the Great Plains Tribal Leaders Health Board. They represent 18 tribes, tribal communities across South Dakota, North Dakota, Nebraska, and Iowa. That sounds like a big job. Dr. O'Connell, thank you so much for taking time to chat with us.
Thank you so much for having me.
So let's just jump right into it. Tribal leaders have asked federal health authorities to declare syphilis a public health emergency. Why is that declaration necessary and what would it accomplish?
Yes, so last year, about a year ago in 2024, our tribal board, which is made up of the tribal leaders of the 18 tribal communities in that four-state area, did send a letter to then HHS Secretary Becerra requesting that he declare a public health emergency around syphilis. And our board felt that that was necessary to increase the resources that we need to respond to the syphilis epidemic that's occurring. You know, as you mentioned in your intro, syphilis rates among American Indians and Alaska Natives are very high. They're higher than any other racial or ethnic group in the country. And the request to the secretary was try to bring more support from the federal government to the region to do a more robust response.
And let me go back to a point I touched on in my intro. The factors that make Native communities so vulnerable to STIs. What's driving this epidemic? And is it fair to call it an epidemic? Do you?
I think it is fair to call it that. Some also use the term syndemic because there's other factors and other issues at play in terms of the outbreak. It's not entirely clear what's driving the syphilis rates nationally, in American Indian communities or in the larger US population as a whole. Rates definitely went up during COVID. So I think we have to acknowledge that there's definitely a correlation with COVID where we saw rates increase significantly around 2020. So kind of makes sense, right? People can't go to the doctor. They're not getting their regular health checks, especially with something like syphilis, as opposed to other STIs like gonorrhea or chlamydia, where you may have symptoms or your partner may have symptoms. A lot of the symptoms that you get with syphilis are non-specific. They go away if you don't get treated, even though you're still infected. Um, and they can seem not like a sexually transmitted infection, right? It can be things like, oh, I just don't feel good, or I have a rash.
Right.
And so people's minds may not go to STIs when you have symptoms of syphilis. Um, so I'm sure that plays a role, but all of the causes that have resulted in this outbreak in the United States are a little unclear. Why are American Indians and Alaska Natives more impacted? I think they just face more barriers to care than other groups on average, right? If you're looking at the area in which I work, it's very rural. People have to travel long distances. Care was very disrupted during COVID. It was already hard to get to, and then it was harder for people to get in. You know, they have to go a long ways. They face a lot of barriers in terms of transportation, right, or taking time off work. And so there's just a lot more barriers to receiving care, for preventative screenings or diagnoses or even getting treated. So someday, I hope we know all of the factors that cause this outbreak so we can prevent another one in the future, and particularly what's driving the rate so high among American Indians. But I still think there's a lot to be learned there, and we don't know everything yet.
You touched on something I think is really important in terms of barriers. A lot of times we think of that as, well, do you have access to healthcare? Do you have the money for copays? But what about transportation? What about getting time off work? And if you get time off work, is it paid? Do you have to choose between your paycheck or a clinic visit? We don't think about those things, but they can be absolute barriers. Let me ask you about something else that can be a barrier: stigma and embarrassment, which are, I mean, with anything related to sexual health care, those things can really come up. But can you speak to what that may be like with STIs in Native American communities?
Sure. I mean, Um, STIs can be, and talking about STIs, as you mentioned, can be embarrassing for people. People may not, whatever community you're in, I think it can be embarrassing for people. It can be
Absolutely.
uncomfortable. Um, in certain American Indian or Alaska Native communities, there might be unique cultural or religious taboos around talking about sex. Again, just kind of like any other community. Um, and who's talking about it with whom in terms of, who's allowed to talk about these things with which people, what people are comfortable with. So I think those are issues you need to be aware of, regardless of whatever community you're working with. Um, we've tried in our work to decrease the stigma. We have one of our staff members who we joke is the voice of syphilis because he's in all our syphilis commercials. Um, and we have lots of public information out there just saying get tested, know your status, get treated, um, and try to talk about getting tested with as little judgment as possible. I'm a family medicine physician by training, and you know, we've seen it all. We have no
Mhm.
judgment. We just want you to be healthy.
Right.
I try to remind people, it's nothing new to us. We want you to come in and tell us what's wrong so we can help you get better or what you're concerned about. So they definitely shouldn't feel any embarrassment or shame when talking with their provider. And so we try to educate people on that, but it can be a barrier for people going in that they just don't kind of want to address those issues, even one-on-one with a provider.
Of course, yeah. We often say at ASHA that we dream of a day when people can talk about sexual health and STIs with the same sort of casual demeanor. Maybe they ask about their flu shot or my cholesterol pill or something like that. So I'm glad that you're doing something there to really proactively help people kind of have that mindset. We have a lot of resources on our website to how to get like 5 things you may want to ask your provider about sexual health. So I think that's good to
And
do. Um,
I
yeah,
I just add, I think it's on the providers as well. I've definitely worked with
yes,
providers that aren't as comfortable or had patients that said, I had a provider that made me feel bad about this or something like that, which should never happen.
yeah.
Our job is to help you. I mean, really, at the end of the day, our job is to help you as a patient with whatever issue you're having. And so it should be a judgment-free zone. And if your patients can tell that you have biases or you're uncomfortable talking about something, that's not useful to them. And so there is some onus on the providers to make sure that they're offering a welcoming space for patients in those interactions as well.
You know what, that's a brilliant point. I remember a survey a few years back, um, after public health authorities were really pushing the idea, say, of annual chlamydia screening for all sexually active young women, I think under 26. And they were talking with some providers who weren't doing that. I was like, well, why aren't you screening, these patients? We have the guidelines here. They're like, oh, well, I don't think my patients are at risk for that. That's not really something, we should have to worry about right in our community. But the fact is everybody needs to worry about it. So yeah, you're spot on there. Let me ask you something. Just this is the last question I have on this topic because I don't want to belabor, but I wanted to ask you about another potential barrier, like historical mistreatment, mistrust of the medical system of the establishment. Would you just talk about how that impacts Native Americans in accessing healthcare?
Sure, and it's not specific to syphilis, although your listeners are probably aware that some of the biggest atrocities around healthcare in this country, perpetuated by the federal government, are related to syphilis, right, in the Tuskegee study. So
Of course.
it's very tied to this particular disease. Uh, but, because American Indians have a unique relationship with the federal government in terms of what's called a trust relationship, and so the federal government is obligated to provide health care for American Indian and Alaska Natives. There is this very different relationship around healthcare that we have with the federal government, and again, they're obligated to provide it, which is great, but that hasn't always been provided in the best way. There's been instances where the providers have done things that are harmful, right, to American Indians, and then of course there's just general mistrust of the federal government overall, because of the history between American
Right.
Indians and Alaska Natives and the federal government. So it's very complicated because, particularly in rural areas, um, for American Indians that live on or near a reservation, the Indian Health Service, IHS, which is the federal agency charged with providing healthcare to American Indians and Alaska Natives, may be the only place you can go. I mean, it's great you have somewhere to go and there's no co-pays, all those things you were talking about before.
Mhm.
Um, but you may not trust them. You might have had bad experiences there, or there may be a history there where things occurred that you're aware of in the past, like forced sterilization of American Indian women, which lasted into the 70s. And so it's a very complicated relationship that can impact not just sexual health, but all aspects of health.
You're being very generous in saying it's a complicated relationship. Yeah, yeah, absolutely. Well, thank you for that. Um, I think broader society tends to refer to Native Americans or American Indians as almost a monolithic term, that encompasses all tribes and nations. But I'm sure there's really a lot of rich diversity, very real differences that we're kind of missing, with such a narrow view. So, what should we think about in terms of messaging and engagement around STI prevention and education? Like maybe what works well with one group wouldn't resonate with another. What do you think about that?
I think that can be definitely true. There's 574 federally recognized tribes in the United States. There are a number of state recognized tribes as well. Some of them are very similar, that come from a similar cultural and historical background. For example, we have a number of tribes that are Lakota, Dakota. They have similarities, even though they're separate tribes now. Um, but there can be tribes that are very close together that are very, very different in their history and cultures, language, Um, and so I think if you're working with Native people or Native communities, really knowing what your kind of hyper local situation is, right? What are your tribes? What are their cultural beliefs? Bringing in people from the community so they can educate you or your staff or, whoever you might be working with on these issues, and bring up those individual cultural concerns or preferences that community members, right, might have, because there are some commonalities that we have across the country, but you're right, when you're really getting down to the on the ground work, you need to have people that know the culture and know the community to be able to guide you in any efforts you're doing around sexual health.
One of the most tragic aspects of syphilis in recent years has been the increase in congenital syphilis or syphilis in newborns. And it's especially frustrating because it's largely preventable. All right. I mean, and just here looking at some of the numbers, rates of infection among newborns are highest among Native Americans, Alaska Natives. I believe the numbers I saw from CDC or Centers for Disease Control and Prevention are 680 per 100,000 live births, which is an absolutely stunning figure. You consider the rate for whites is like 57 per 100,000. So, uh, I mean, I almost don't even know what to ask you about that. I'm just sort of mind boggled. What can we do to improve these numbers?
Yeah, they are very high. If you go to the CDC website and you can look at the syphilis graphs, they actually go back to 1941, and the syphilis rates in American Indians are higher than they were in 1941 when we didn't have a treatment. So they are very, very high right now, among American Indian and Alaska Native people. A couple I'll get to your question, but I want to point out a couple things about this outbreak. One of the things that we're seeing in the last few years in syphilis among American Indians and Alaska Natives that are helping drive these very high rates of congenital syphilis is that there are a lot of Native women getting syphilis. So if you've worked around sexual health in the last 10, 20 years, or maybe even a few decades beyond that, syphilis was always primarily thought to be a disease among men who have sex with men, right? It wasn't thought to
Right.
be transmitted through heterosexual sex to women of childbearing age. Of course, it can be, but that wasn't kind of the primary driver of syphilis cases in the United States. With this particular outbreak, what we've seen, particularly among American Indians, is that the people who are getting it are women of childbearing age, Native women in particular of childbearing age. And in our region, the vast majority of cases are transmitted through heterosexual contact, 95, 98% of the cases. It's very unusual in what I think kind of public health and sexual health is used to in the last recent memory in terms of how syphilis is transmitted and who's getting it. And so, because of this more unique in recent times demographic of who's getting infected, that definitely pushes up the congenital syphilis rates. Because if you have a lot of heterosexual transmission of syphilis,
Sure.
right, you're going to get a lot of people who are pregnant and been exposed and infected with syphilis. So I think that's a really important thing for people to know if you're working in these communities. It's a little bit different. We need to really focus on heterosexual transmission in Native communities. I'm not saying it's not occurring in others, but it's definitely driving the current epidemic among American Indians. Uh,
Right. Okay.
so to your point, congenital syphilis is basically preventable. There's a few situations where it's not, but if you are able to treat mom with appropriate penicillin at least 30 days before she delivers, nearly all babies will not be born with congenital syphilis. So it is an entirely preventable illness with penicillin, which has been along forever, right?
Yeah.
Um, so what we're seeing again among American Indian women, not only are more of them getting syphilis, right? So you're going to have more babies with congenital syphilis. Native women lack access to prenatal care. So they're not able to receive the screenings and treatments they need. So if you look at the region that I work in, North Dakota, South Dakota, and Nebraska are three of the states with the highest rate of maternity care deserts, according to the March of Dimes, which means that the number of counties that people live in that have zero access to prenatal care of any sort or maternity care of any sort. So it's somewhat unsurprising that you're seeing in an outbreak setting of syphilis that you're seeing all these babies being born with congenital syphilis because people don't have anywhere to go for their prenatal care. They can't get screened, they can't get treated. You're unable, it's difficult to prevent those cases when people don't have the ability to go to the doctor because literally there's no one there to see them.
That is one of the most chilling phrases I've ever heard, maternity care desert. I mean, it that takes me back to one of I've been at Asher for almost 28 years. I've been here forever. And I have some catchphrases I've developed over the years. And one of them is, we have the means to prevent these issues. The question is, do we have the will? That's one of my lines. And I've just kept thinking of that as I was listening.
Kind of to that point, the little data that is available seems to suggest that if women are able to receive prenatal care, regular prenatal care, they are not having babies with congenital syphilis, right?
Sure.
So they are getting screened 3 times, right? At first visit, at
Hmm.
trimester, and at delivery. They're getting the penicillin they need. Um, and so all of these cases, not all, but nearly all of the cases that we're seeing are in women that aren't able to have regular prenatal care. So maybe they don't have any, maybe they have a visit or two, or it's very fragmented or
Sure.
interrupted. But those those are the women that are having babies with congenital syphilis at this point, right? The women who are receiving prenatal care for the most part are not having babies with congenital syphilis, which wasn't necessarily the case at the beginning of the outbreak, right? But at this point,
Yeah.
the women that are having babies with congenital syphilis are not receiving regular prenatal care.
That's thank you for stating that so clearly and eloquently. Okay. So let me ask you, if you're talking with someone who's pregnant or they may be someday, what's your 30-second elevator speech to tell them what to do to protect themselves and their baby?
Definitely get screened for syphilis. Make your partners get screened. Even better, make everybody get screened before you have unprotected sex. Condoms, use condoms when you're having sex, of course, if you're able. Obviously, if you're trying to get pregnant, you don't want to use condoms. So definitely get everybody screened for STDs before you try to have a baby. That's the best way to go to have a healthy baby, right? Even if you can't access prenatal care regularly, which as a family doctor who is trained in OB and used to do OB, I certainly endorse. But at the very least, make sure everybody's screened for STDs because there's a number of STDs that can be harmful to you and your baby and your partner. And so making sure that they're all treated or cured before you get pregnant is, of course, the best course of action, right? Prevention is always the best course of action.
Mm. We've been talking with Dr. Megan Curry O'Connell with the Great Plains Tribal Leaders Health Board. Uh, I mean, I don't know what to say. Thank you for your time and insights. That was amazing. You really, you gave us a lot to think about there. I feel like we need to do a follow-up on this somehow. I'll have to think that through. So I can't promise I won't email you again, but thank you. Thank you.
Be happy to join you again. Thank you so much for having me on and talk about syphilis, which we're still fighting in the Great Plains, and probably will be for a while, but been doing a lot of work to keep the spread contained as much as possible.
You know, your organization does a lot of good work. I was on the website, and we'll link to Dr. O'Connell's organization, in the show notes. Take a visit, take a minute to visit their site. It's really worth a look. On the homepage, there is this visually sumptuous animated video called Beartooth, The Dark Reflection. It's part of, I think, the opioid and meth prevention series outreach. I watched it last night when I was prepping for our conversation. It's just was like, wow, there's a lot there. You really are doing. You've got a big job. So
Well, I am so grateful to work for the health board. I have an amazing team of people I work with. And, just to plug the health board a little bit, it is a tribal organization. So my bosses are the elected leaders of the 18 tribal communities in the Great Plains area. So they're setting the priorities and giving us the direction. And then the amazing people that I get to work with every day do things like make videos, like you're saying, and go out and
yeah,
educate people about syphilis and do contact tracing and test people. And so I agree with you. I think it's a great organization, and we do great work. But it's all the amazing people I work with that are out there, in the communities doing these things to help our
sure.
relatives across the Great Plains.
Well, I'm glad you are. Thank you and your colleagues for everything that you're doing. Thank you for this great conversation. And thank you, intrepid listeners, for joining us. As always, keep in touch. We are at info@ashasexualhealth.org. Let us know if there's a podcast topic you'd like us to talk about. As I said, we are linking to Dr. O'Connell's organization, so be sure to check them out. It's definitely worth a visit. We will see you next time. Goodbye, everybody.